Excellent. Well done, John. I think you've done it.
Right, good.
Okay, so let's make a start. So good evening, ladies and gentlemen, and welcome to the Adults Health and Social Care Scrutiny Board on the 2nd of November 2023 on this very dark and miserable evening. So we'll have a few things to go through on the agenda. Appreciate your attendance this evening. So let's go on to item number 1. So substitutes nominated for the meeting.
Oh, God. Hang on a minute. Something's happened.
Okay, thank you. So, item 1, can we have substitutes nominated, please?
Yes, Chair, we have councillor substituting for.
I was going to say that doesn't sound like Howard.
No.
And can I remind members the need to declare any disclosure?
That isn't Howard.
No.
I can guarantee that's not Howard. His lips never moved.
Is that Steve Sweeney's voice? I think that's
Steve. At the top of my screen, my YouTube.
It's showing it's live, doesn't it? Yeah.
Yeah.
It does. If you can just bear with me.
Yeah, Steve Sweeney from when he was chair of planning.
I do apologise.
Quite unnerving.
No need.
Can you mute yourself? Can you mute yourself, Janet? And will that stop us hearing it?
Possibly.
Might still distract you, but it might stop us hearing it.
Okay, thank you.
I've muted myself.
You have now, yes, indeed. Thank you, Jared. Right, okay, so substitutes nominated for this meeting and apologies for absence. So I have apologies from Councillor Benton and a substitute. We have Councillor Atkinson, not quite in the room yet. So we'll wait his presence. So item number 2 is members' interest for members to declare their interests at the relevant time. Welcome, Councillor Atkinson, and thank you for being a substitute this evening. So thank you for that. Item number 3, admissions to the public. It is not recommended that the public be excluded from the meeting for consideration of the business on this agenda. So everyone out there who's listening on YouTube, you're most welcome. And hope you find it's an extremely useful meeting as we prepare for winter. Item number 4, minutes of the Adults Health and Social Care Scrutiny meeting held on the 27th of September 2023. They have been circulated today, and apologies were provided for the late production of those. Councillor Hutchinson, do you have something to add on that?
Yeah, can I just check with the other members on the 3rd page of the minutes, just above where it says it was agreed, it says digital communication should not be the first port of call. I thought we'd decided that it should ask that it shouldn't be the only
point, yes.
Because a lot of people do find it quite convenient for quite a lot of what they're wanting to do.
Indeed. So with that amendment, could I move the minutes as circulated? Could I have a second?
Just also, we were promised the numbers of physician associates at work in primary care practices. I'm not aware that we've had that information yet. So if that could, the participants could be reminded that because that was something of some concern for people.
Indeed, Mike Lodges agreed to chase that up. So thank you, Councillor Hutchinson, for that.
With that proviso, I'm happy to move.
Super, right. There's a second as well. All those in favour? Yeah, super, fantastic. Item number 5 is deputations, but we received no deputations as of 12 noon yesterday. So there's no items for discussion on that section. And item number 6, which is a big item agenda, which is the preparing for winter. So it certainly feels like winter today. And this is a Head of Integration and Partnership NHS. So Debbie, welcome, Debbie, on this one. We have had your very comprehensive report. I'm sure you may wish to add to the report itself.
Thank you. Thanks, Councillor Blackburn. So I have two colleagues here today. So Debs Harkins and Kath O'Malley. Unfortunately, we've got apologies from our colleagues at CHFT. It is their staff awards night, which is something very important to the organisation. And the two people that were coming have actually been nominated for awards and therefore have to be there tonight. So what they've agreed is if there are any questions that cannot be picked up by any of the three of us, we will get those back to you as soon as possible. So apologies for that.
No problem at all.
So just in terms of the papers that you've got a few things really. So it just really talks about the fact that all our winter planning is pretty much done by the Calderdale Urgent and Emergency Care Board. That board is chaired by a GP in Calderdale, but it spans the CHFT footprint, so Kirklees and Calderdale. I know there's a lot of things in the pack, but with the overview paper tries to kind of just make some sense of those. So the first thing that we did is we've used the work that the Health and Wellbeing Board did with Debs Harkins, which was to look, I think, for the first time at winter through the lens of delivery of the wellbeing strategy, so that it doesn't come across as purely an individual organisational approach, but talks about how our plans meet the needs of children, older adults, etc. So hopefully that's in section 2 of the cover report. We then go on in the report just to talk about the winter funding. So each year we get a relatively small amount of winter funding, just over £1 million. It's non-recurrent. We've managed to do some really good stuff with that, particularly setting up acute respiratory hubs in primary care and also extended general practice access through Sundays and bank holidays. We've also had to put in two big documents, and those are the documents that are attached. So the first one is our winter narrative that gives an overview of our approach and insights from each organisation. That's attached as Appendix A. And then Appendix B is the resilience plan, which talks about how we're going to manage as a system through winter. We've completed all those documents. So documents have been submitted and have received, I'm not going to say quite a stamp of approval, but have been assured as being good and fit for purpose. I think the documents particularly identify that whatever plans we put in as a system, winter is always a very difficult time and we never know what's ahead of us. So I guess the most uncertain factors are those around things like our workforce, health, infections in the community, demand threatening to override our capacity, and things like the fragility of our care home market. But with all that being said, we feel that we've mitigated as far as we possibly can what's ahead of us, albeit we are not complacent, and that work continues. So that's all I'd say really, Councillor Blackburn, because I know members will have questions and I didn't want to go and do too much as an introduction.
No, that's absolutely spot on in terms of the introduction. Debs, do you have anything to add to that?
If I may, just Councillor Blackburn, just I suppose the other point that the paper that we did for the Health and Wellbeing Board, that's in the first bit of the document pack that you've got. One of the conversations that we had at the Health and Wellbeing Board in relation to that was how we get into the position where we're really adopting those 4 ways of working that we've all signed up to. So focusing more on prevention, joining up services, really looking at the root causes and empowering communities to play their part. How do we, if we really embed those ways of working, that's the way that we're going to get a more sustainable health and care system. Yes, winter's always going to be a challenge. There's always going to be seasonal variations that are going to be a challenge, but very important really for us to raise our heads up and think about dealing with this winter, but also think about how we get how our system becomes more sustainable in the future. So what we've signed up to do in future years is almost use that wellbeing strategy as a framework to think about our winter planning prospectively as we're doing the planning, as well as a sort of retrospectively, which is what we've done this year. So that's all I'd add, Chair.
Super, thank you, Debs. So before I bring members in, Kath Gamal, do you have anything to add to that as well?
No, thanks, Councillor Blabber. No, I think it's all in the pack, and I think Debbie and Debs have articulated that overview really well. So happy to answer any questions.
Superb. Well, Councillor Riffon, I think you had your hand up first, so welcome to the meeting.
Thank you very much, Chair. And apologise, I had a few technical problems joining. One thing I particularly wanted to raise in terms of prevention, and this might be here, but perhaps I think doesn't have the emphasis it should, and that is issues around dry and warm housing. We've had some very concerning issues raised about mould and respiratory infections, sadly resulting in tragedies. And whilst it might be beyond, but in terms of how we work with partners, particularly perhaps social landlords and others, in terms of making sure everybody has a safe and dry housing, and that this doesn't become another factor to increase the risk of respiratory disease. And I wondered what your thought, obviously, in addition to the other factors about the importance of being warm and dry during the winter. And I just wondered about your thoughts on that.
Debs, you want to come in back in on that? So Debbie, sorry, yeah.
I mean, if oh, go on, sorry.
No,
go on,
no, I meant you, Debs, you, yes.
Yeah, I mean, it's a real challenge. I don't think there's any two ways about it, Councillor Riffon. It is a real challenge. We have done some work as an organisation to invest a little bit of additional resource through into our environmental health team to ensure that we're stepping up, got a bit more capacity to do that identification of sort of damp and mould in homes. We're also very much part of a West Yorkshire health and housing programme that operates across West Yorkshire, where we're working really hard to try and ensure that people whose health is at the greatest risk of poor housing, we can find ways to make sure they get some support. We have a very good in Calderdale housing and health team, but I wouldn't want you to think this is not an enormous challenge, really, and that we haven't got the resources that we need to ensure that everybody is in housing that can keep them healthy, protected and safe in the winter. But we're doing, I believe, partners and other parts of the council particularly doing all we can really to try and proactively identify some of those risks that have emerged more recently, particularly in relation to mould.
Thanks, Deb. I suppose one thing through our press we could really do with ensuring that those who are entitled to winter fuel allowance are actually getting it and have applied for it, because I think that's it does have some, it does help. It doesn't go a long way, but it certainly it would help. So I think some form of press release ensuring that this is available. I think I presume you have to apply for it. I don't know. I'm not at that age yet, so I don't know. So my apologies. Right. So the next one I have is Councillor Kingston.
Thank you very much. I have a few questions, just a few things that I've highlighted in the report, the first report, the one that's done in the style of looking at it through that lens of the organisational structure that we've identified. I really did appreciate that way of looking at it. I liked that framework, Deb, so it's great. Thank you. And just a comment about the other two reports, the appendix reports. When I was a teacher, we used to talk about death by 1,000 worksheets. Now I'm a Scrutiny member. I feel like it's death by 1,000 acronyms. I just wonder if we could have a cap on the number of acronyms that are used in reports without explanation, because I have to look so much of them up. And really, it's a time waste. You could just not use an acronym, or at least the very first time you use it, use the full wording and then put it in brackets afterwards, so that I'm not searching through documents to see have I missed the explanation for what this acronym means. Just a little gripe.
Well, that's
Right.
a
So my actual questions are about the there was something about high visibility clothing for making children safer on the way to school in winter, which made a lot of sense to me. But I wondered, have we got some kind of thing in place to provide that? Is that assistance that we give to families in Calderdale in order to have high visibility clothing? Do we have that? Do you want me to ask my other questions as well so you can answer them all, or do you want to deal with them one by one?
I think if we deal one by one, then we're not overburdening
That's a good idea. Yes.
Yeah. So, who would like to come back on? Debs, do you want to?
I can try. My understanding is there are some. That's the reason that it's in the paper, is that there are some examples of that, but I'm not sure. Councillor Kingston, I'll have to go away and find out whether that's routinely available or if that's more of an ad hoc provision.
I think this is probably more school based. That actually, the walking groups, you often see the walking children to school, which where you see them.
Of course. Yeah, that makes sense. Yes, thank you. Okay. And then there was a thing about access to talking therapies in order to deal with the depression that lots of people get through winter and that affects work absences and such. And I'm aware that nationally there's a major problem with access to talking therapies with huge long waiting lists. And I wondered, what's the position here in Calderdale with that? Are people waiting ridiculous lengths of time for talking therapies?
I'll let Debs come in on that. There is also the talking newspapers. I know it's a slightly different thing, but it might equally help as well. So that's something to just bear in mind, I think. So I'll let Debs now come in with the waiting time for your official question.
I haven't got it in front of it. I can certainly find that for you. So I know there's a lot of investment in Calderdale gone into talking therapies, recognising its importance in terms of an emotional wellbeing journey. I believe there's additional investment being put in terms of the actual numbers waiting. Councillor Kingston, I can come back on that. Anything that I write down, I'll come back to Mike and just provide all the data back.
Okay, and then my other thing was this Choose Well winter communication campaign. There was nothing about what that is. What is that? What is the Choose Well winter communication campaign? What's in it? What's it about? And I'll leave it at that as my final question.
Okay, thank you for that. So the Choose Well campaign is a campaign that was initially actually started in Calderdale, and it supports families and individuals in Calderdale to understand where all the access points are. So, for example, do they know the services that are provided in community pharmacies? There are all sorts of new services and self-care. So it was very successfully evaluated in Calderdale 2 years ago, and as a result of that, the whole of West Yorkshire have now created the same. So we now have a West Yorkshire movement with all the same comms in. And this year we are particularly focusing on we've got some analysis of the reasons why people might go to an emergency department for very non-urgent and very minor conditions, which to them might be important, and trying to focus then on those groups of people and trying to share information about those other. So if the Choose Well is choose well for your family, but does involve a degree of self-care also.
Thank you very much.
Yeah, no, thanks. I'm just going to come back to Councillor Rivron's point, actually, and this is another element of it, and this is about Together Housing have a charity arm which helps to promote other areas of like slow cookers and air fryers and things that would help people reduce the energy costs so they can actually heat and it's more affordable. So it's just something to really point out to the rest of the members, I guess, in some ways. Councillor Hutchinson, please.
Thank you, Chair. I have several questions, I'm afraid.
I thought you might have, given the length of the document.
First of all, I was wondering whether we have sufficient capacity for COVID testing prior to discharge of patients from hospital to care homes. On page 27, it suggests that there's a risk that care homes might not be willing to accept discharged patients. So I just wanted to be sure that no patient is going to be discharged to care homes without a negative COVID test, because things didn't go well last time. Or whether there are care homes now that have isolation facilities that would be able to take patients who haven't been tested.
I don't know if shall I start on that, Deb? So yes, CHFT in their planning, I believe, have tried to secure as much of that capacity, and they have an analyzer. They have analyzer capacity that they secured during COVID that would increase the capacity they would have had, obviously, pre that period. And there are some care homes that do have a proportion of beds where they're able to, well, not beds, but parts of wings where they're able to take people who have not had a negative test. I think this is a constant communication, and we have one of the things we've invested in as part of winter funding are roles called trusted assessors, and the role would provide a much more of a interface between the care home and the hospital, not just about COVID, but about any concerns about discharge, to prevent times when those discharges have not worked well, but also to provide assurance about if the patient becomes unwell, once they're in the care home, how very quickly they can be accessing some form of clinical support. So I believe that CHFT are in the right place. I think it's an ongoing kind of a interface conversation about what homes are prepared to take, and we understand that it's very difficult for them in those situations. I don't know, Deb, if you've got any more you want to say on that.
That's what you've said is absolutely is absolutely right, Debbie. And I think just to assure members of the Scrutiny Board, we have never ever stepped down any of the surveillance that we've been undertaking with care homes. Every day we still contact care homes. We still check, have they got anybody with COVID? We still, if they do, we still offer that support. We've got the same level of support in relation to, but not just COVID, but flu and other infectious diseases that we had at the height of the pandemic. We've still got those systems in place, and we've also got those systems, haven't we, Kath, that where there is, and Jill, where there is an issue and an outbreak, we are able to step up that sort of coordination right across the system, across public health, across adult social care, across commissioning, and with our colleagues in the health service. So of course, periodically there are issues, but we're able to get on them really, really quickly because of that sort of daily surveillance. Well, 5 days a week surveillance that we're still continuing to undertake.
Thanks. Along the same theme, we're a little way into the vaccination programme for this year now. I wondered what the current level of uptake of flu and COVID vaccination was amongst hospital and care home staff, amongst healthcare and home care staff in the community, and amongst care home residents and housebound people. Whether we know where we are with that.
I could quite easily find out with a couple of because we've had a report. We keep a weekly uptake. Obviously, care home and housebound patients were our first priority with this most recent round. I understand the uptake is high. In terms of staff uptake, I haven't got it to hand, but I could check while we're on this call.
Okay, thanks, Debbie. Then on page 9, it mentions the gathering place, and I was wondering what kind. It says support is being provided, but I was wondering what kind of support is being provided. Particularly, we know that previously there have been problems with getting medical care for homeless people, which was addressed through, I think, through the burnt bridges fallout. I was wondering, hoping that that's continuing.
I don't know who's best placed to answer that, whether that's Deb's.
Yeah.
If it's okay, sorry, Chair, but yeah, absolutely. The winter shelter, our drug and alcohol services, some of our high risk places where we know there are vulnerable people. Again, the lessons that we learned from burnt bridges around really joining up the support that we take out to those settings. It's been transformational. I know Libby's quite involved in some of the work as well, the group that oversees that. We have a multidisciplinary team. We had a fabulous session. I got some lovely feedback from the vaccination, from the Health Inequalities vaccination team on my return from leave, to say what a fabulous session that they'd had at the Happy Days at the Gathering Place, in terms of giving both flu and COVID vaccines to residents. They're given more than we've ever done before in the period of time. And actually, we give a number of first ever COVID vaccines to the people that were there. So very much carrying on that good work. And Libby probably can give you a little bit more detail about some of that. But I feel it's been really transformational. I think we'll carry on working in that way for a very long time, if not forever.
Yeah, I think the significant thing I'd add, Debs, would be the wound clinic and the primary care nurses that are actually sort of treating people with quite significant problems with their legs and various ulcers. And certainly kind of we saw evidence of that when we met with the Department of Health in terms of the pictures that they were kind of showing, but also just the relationship that those primary care nurses had with people who had those really extreme problems. So I think it's the first time I've known, Councillor Hutchison, where primary care has been really present, but also mental health care. So very much kind of tied in with mental health services and colleagues within South West Yorkshire Mental Health kind of partnership sort of trust, very much being very flexible and seeing people kind of very readily outside of appointments. So I think that very large kind of multidisciplinary team that meets on a fortnightly or weekly basis sometimes has proved to be really effective, plus the ability to kind of, one of the joys of screen time is that we can really pull a very quick meeting together with the right people if there is an issue for somebody on the day.
That's great to hear that's not fallen off the agenda.
I think it's built and developed rather than got the risk of falling off. It's just getting bigger.
Super, thanks, Libby. Debbie, do you want to come in? I think you have your hand up, so yeah.
Yes, so just in terms of the uptake, so at the moment, so this is as of today, so just care home residents for COVID is at 65.6%, and for housebound 52.3%, and for flu for care homes it's 69.2% and 54.5%. So we're partway through the campaign. The bit that I haven't got to hand is the staff uptake, but that's something that I can get hold of.
No.
Thanks, Debbie. Yeah, thank you.
That's thanks for that, Debbie. I was wondering if you could say a little bit more about these 3 acute respiratory infection hubs that are mentioned, as to how they actually function. Are they people directed there by 111 or at the front door of A&E, or after they've been seen by a GP? I mean, is there any overlap in, that stuff is done in primary care and then they're referred on to the respiratory hub? And I just wonder what actually takes place. There's mention of a trial of point of care testing to target antibiotic use appropriately. But what testing is that?
So at the moment, so we've 3 hubs in Calderdale, and can certainly share more detail on this. So they basically are referrals from any general practice in Calderdale. It covers that, those hubs cover all of Calderdale, and those patients can go directly there instead of needing to go to their GP. Part of that aim is to keep people with a respiratory infection out of the waiting rooms that we've also got 111, some element of 111 access to that. The other thing that we're planning is to have a direct bookable appointments also from our emergency departments into our what we call ARI hubs, so acute respiratory hubs. They can prescribe, and they are not quite yet, but they are planning to do point of care testing also that would be able to give patients a really quick turnaround time in terms of what form of intervention. They also have very strong links with the paediatric respiratory team at CHFT, so that for any, particularly for children who come through that route who do need something more, there's also access to same day urgent care in their own practice should they need it. So the hub works to bring as many people through. Utilisation, I looked this morning, utilisation is about 97%, so the vast majority of the appointments that we have available through that system are actually being utilised. I couldn't say more, Colin. Sorry, Councillor Hutchinson, if you'd like, I've got a decent description that went out.
I just wondered what test people were getting that would say whether you need which antibiotic you need at point of care, because
I'll see if I can check while we're on. I've got something. If not, I'll follow it up with the data.
And I've just got one more question, Chair, if that's all
yeah,
right.
go ahead, Councillor Hutchinson.
Thanks. I see that funding's been received for a single point of access to district nursing services. But I was wondering what our current establishment for qualified district nurses actually is in Calderdale, and to just check whether they still provide round the clock care 24/7.
So I think
yes. I know not every area does.
Sorry, Councillor. Yes, so can confirm it is a 24/7 service, and I think that also links with the palliative care team who work similar around the clock. In terms of the current establishment of qualified district nurses, that's something I could definitely ask the HFT colleagues for.
Thanks. That's great. Thank you very much.
Thank you, Councillor Hutchinson. I just have two things. One is shingles seems to be on the increase, and there's a national vaccination programme. And I understand that over 65s were able to have it from September, but we certainly had some feedback that that's not actually been the case. I'm not quite sure about that. And the other element I wanted to raise was the impact of the new A&E actually, and whether this is taken into consideration with the plans as to and is everything going according to plan? Have there been any teething problems in relation to the new A&E? I presume not, because we're not being informed, but it would be not right to me not to raise those questions, I guess.
In terms of the new ED, so yes, the planning takes into account, especially at HRI, once the ED is fully up and running, the space that is there will become an integrated discharge hub, so to really kind of improve the patient journey for people being discharged. Or we're just awaiting the final date. They have done, I know, a good deal of walkarounds for residents, which have proved very popular. I think they are ready to go. They're just doing, I think, the usual snagging, etc. But again, I can seek an update from CHFT on timeline.
Certainly, the visit I went on it looks quite amazing. Actually, it was really nice.
It is.
To get to that stage. Debs, do you want to come in on?
It'd be shingles vaccination, Councillor Blagborough. Yeah, just to say that it's recommended that that people who are it's the programme is developing and changing. So people adults turning 65 those aged 70 to 79 and those aged 50 and over with a weakened immune system are all eligible for the shingles vaccine. The new eligibility, the including adults turning 65, it's been implemented. So it's been done in almost waves of people, of cohorts of people. So people just turning 65 are eligible. Next year it'll be the people that are just turning 65, etc. And by having those age groups, gradually we'll get that whole population vaccinated. In terms of the uptake and how that's going since the changes, I don't know the answer to that question, but I can definitely find out how that's going in Calderdale in terms of the uptake.
Super, thank you for that, Debs. Councillor Barnes.
Thank you, Chair. First of all, kudos to Councillor Riveron. First hand up, always impressive. Second, Section 4, planning priorities, winter planning in July 2023, etc., etc. And there's five points there. I did find it very difficult to identify in this report where we were against all those. Where, you know, we're growing the workforce, where we're improving discharge. I did find it really difficult to go through it, to identify where the links were, because it is, you know, I'm sorry, but it's just too big a report for that to go through. So where are we against those priorities in a nutshell tonight? And secondly, if you were to come back in April next year, how would we measure the success against this? And I don't just mean that we've had a light winter and the weather wasn't that great and therefore we've had it. How would we measure success? Because measuring the success is when the system is put under, for want of a better word, stress. Thank you, Chair.
Thank you. Debbie, sorry, yeah.
Okay, I'm going to have to go. I'm going to have to just find, because I'm scrolling through the document, I'm going to have to find the 5. But I guess just talking about discharge is probably one of the key ones. So in Calderdale, we have been successful in getting, I think it's 1.17 million recurrently, which is recurrent money, which is usually very difficult to find. And we've invested that, and Kath, I know is on the call and leading this, but invested in an integrated discharge model, which is a decent amount of new staff. Those staff are predominantly staff that will work out in the community and support people to be discharged. So independent living workers, reablement staff. So we have a new model of care that is, well, a new model of discharge that is brand new, and we know, although we're in the process at the moment of recruiting teams into that, it's the joint recruitment between the hospital and Kath's team. That's something that we think is going to be a game changer for us in Calderdale. I don't know if Kath wants to pick up any more on that while I look at the other 5. I'm just going to scroll through some documents.
I think Councillor Barnes has made the point that it's a big document. so thank you for that.
Chair, can I just go back before Debbie? I'm not asking necessarily you to do it tonight. I think if you could come back afterwards.
Okay.
I don't want you to rush through something tonight. If you could come back to us afterwards and drop us a note as to where we are, that would be brilliant. Thank you.
I'll certainly do that. And just to say, recognise these documents are really unwieldy.
I know you haven't. You've said that.
And they are for an NHS England audience. And they're not great to read through yet. So I will definitely, and I think the point you're making also is, we can say where we are now with those things, but it's about coming back in July and saying, and how did we do on all those things? So I totally get that. Thank you for that.
It did help me to get to sleep the last few nights, so that's thanks for that, Kath.
Thanks, Councillor Blackburn. I think the only thing I would like to add really is about what Debbie said about the discharge to assess home first model being a game changer. You know, I think it's progressing well. We've got quite a way to go in terms of the recruitment yet, and we're keeping an eye on that. But we've got weekly. I think the strength of the system is something that is really important. So we've got weekly discharge exec meeting that I chair. And we've now extended that to Kirklees as well, so we can see across the CHFT footprint as well. And our council colleagues in in Calderdale and Police Council work really closely together, as do the clinical staff as well. So I think one of the things one of the measures of success for me would be that the home first model gets people home, gets people to the right destination wherever possible, that they can go home to their own bed with support rather than going into a transitional bed or a temporary short stay residential placement, etc. And then that risks further deconditioning, etc. So I think it's having that real person-centered approach, really strengths-based approach, supported by the voluntary sector as well, and getting people home. But I guess the other bit is also preventing hospital admission as well. So all those things within the winter plan, and particularly around kind of resilient communities and working with our voluntary sector, who've done fantastic work around communication and kind of communicating to people what is in the community to help prevent social isolation, poor ill health, falls, etc. And therefore, kind of admission to hospital. But so I think that is that different approach, that real joined up, integrated partnership working approach, I think is a game changer. So that would be a measure of success for me.
Thank you, Kath. Yeah. Councillor Atkinson.
Oh, thanks, Chair. Mine's a quick question about respiratory illnesses and obviously winter pressures and staffing. This is more drawn from I read the minutes of the last meeting this morning. It's more drawn from that. I think surely the goal should be having as much staff and lines of defence as possible. But as I was in the minutes of the meeting, I was seeing sort of a bit of criticism against physician associates. But I just think extra staff helping GP, obviously treating patients, should be applauded and not criticised, rather than focusing on job titles and who's who. Ultimately, I just think more focus on patient outcomes and internal politics in the NHS.
Yeah,
Thanks,
well made, Councillor Atkinson.
I've got to declare an interest when physician associates are mentioned because I work for the General Medical Council.
Thank you for declaring that interest. It's been an absolute excellent. It has been an excellent report. It's been made more excellent because of the summary that you provided us with, because that actually was really helpful. And I think our thanks go in advance of the winter period to all those who work in the healthcare system. It is challenging at the best of times. It seems to be becoming even more challenging, and the pressures and everything on those lines. So really a big thanks from the Scrutiny board here in Calderdale to say, well done for working together and helping to improve people's lives, and as we go through what feels like tonight a long winter ahead. When you look at the miserable weather, the wet and everything on those lines. So very much appreciate the reports. Appreciate the coming back with the answers, or some of the answers. So thank you, Debbie, and thank you, Debs and Kath. So thank you. So I think that
thank you.
So we will keep a watching brief over the periods, and as and when if things do get serious, we clearly would like to be involved and help in some ways. So thank you once again for presenting this report. It is a key report moving into a period that's going to be quite challenging. So thank you for that. So we now move on to, for those who, Debs and Debbie, if you need to leave, you're more than welcome to do so. So thank you for your attendance. So we now go on to Deprivation of Liberty and Mental Health Act. Thank you, Olivia, for attending. I believe Sean is on annual leave. Hope he's having a restful time when he'll come back to perhaps a few challenging questions about this report. So it's not aimed at you. It's really what we're here to do is to be your critical friend, or the department's critical friend, as you well aware. And welcome, Jill, as well. I think this is a joint report. So over to you, Olivia. We've had the reports, but I think you may have a slight presentation.
Yeah, I guess I'm assuming that you've had the PowerPoint presentation
We
forwarded
have.
to councillors. Brilliant.
We have, yeah.
So what we've tried to do within just the PowerPoint is just kind of give a real kind of overview of the legislation for both the Mental Capacity Act and the Mental Health Act, and just to kind of give a bit of a flavour really. And I think kind of when we were asked to do this, it was just very much kind of what we were asked to give you as a bit of a walk through in terms of how people are deprived of their liberty, both either through the Mental Capacity and kind of Dole's Act and the Mental Health Act. So we'll kind of go through I don't particularly kind of intend to go through slide by slide unless you really want me to.
You've been to my meeting before.
I have. So I guess kind of the main thing really that in terms of deprivation of liberty is that there are two kind of elements. One is deprivation of liberty, which is kind of used in terms of care homes and hospitals, which gives us a legal framework in which to which gives us as the Calderdale Council as a supervisory body to authorise a deprivation of liberty on somebody who's ordinary resident in Calderdale. And the deprivation of liberty safeguard is used for people in the community, but only the Court of Protection can grant that. So we would apply to the Court of Protection to kind of grant that. So there are the 5 fundamental principles that kind of underpin it in terms of the Act in 2005. And the basic one is that we must assume that somebody has capacity unless it's established that the person lacks capacity. And that it's decision focused. So capacity is not a global thing. It's very much based on the decision and any kind of steps that we might kind of make in order to kind of, so often those decisions are around, can people kind of, have they got the capacity to agree to their care and support needs? Have they got the capacity, particularly kind of around the sort of care homes in terms of, you know, are they under constant supervision for their safety? So the Capacity Act allows us some restraint and restrictions. And for example, that would be things like applying a bed rail to a bed, or putting a lap belt on somebody in terms of supporting them with their movement, but also kind of any physical holds that we might put in you know, so if it's either redirecting somebody to a room, so rather than kind of full-on restraint. The DOLS, it gives us the authority to be least restrictive, and it can be on one issue or it can be on multiple issues. So I guess I think, as I've said, there are 6 assessments that we have to take into account. So deprivation of liberty is used for people over the age of 18. It is determined about their capacity. It can be around their care and treatment. It's around that if, you know, sometimes people don't refuse care and treatment, and the other thing that we may do is look at best interest in order to place somebody in a particular setting, and that best interest is both kind of around their health and their well-being. So I guess there's something for me about kind of, you know, kind of part of why I'm here tonight is really to answer people's questions around deprivation of liberty. So we've kind of given a little bit of figures. So we've given you the sort of kind of the last year's and this year's figures around England, Yorkshire and Humber, and broken that down to Calderdale. And one of the, and as you can kind of see from the figures, then there's been a reduction in particularly kind of the Asian British from last year to this year, but there's been an overall rise in the numbers in Calderdale from 730 to 814. And reductions are often come around because people may have died, or they may have moved out for a particular setting. We will get, if we kind of look at the data, we probably get on average around 37 referrals a month. And And out of those 37 referrals, we would class 26 of those as being quite urgent. And that may be because people might already be challenging or appealing or objecting, or they may have no family. So we would be very much kind of focusing on people that are there with that. I guess what I'm going to do is stop there and see if people have got questions around deprivation of liberty before we might move on to Mental Health Act.
Indeed, super. I'm just looking around the room. Nobody. Oh yes, Councillor Hutchinson.
Yeah, thank you, Chair. I mean, the reason, if I take you back, this came out of the scrutiny report into Buying Our Care, which was of a limited number, limited but important sector of the population that we're considering, and recommendation 7 from that report was, we recommend that families are supported through the court of protection process. The procedures of the court should be explained to them in a clear manner, and if necessary in the first language of the family. The independent advocacy services should always be clearly signposted to family members. And the background material that you directed us towards was really helpful. So thank you very much for that, because there was a lot in it that I recognised from themes that arose during those scrutiny discussions. In applying the Mental Capacity Act, it states it is vital to reflect on the way that societal values, professional values, personal values, and the values of the service user influence the assessment process. And also, you need to be aware of power imbalances and professional roles and identity which can suppress the patient's voice within the assessment process, which, as I say, I think we'd heard some of that in terms of the stories that were given. I know it straight into not from the deprivation of liberty so much as the application of the Mental Health Act, but in terms of the court of protection, unless families understand the importance of the court, they may miss the opportunity to contribute to reaching the optimum solution. So it's important that they know how to prepare for this. And many councils provide information booklets explaining the workings of the court of protection. And we recommended that Calderdale do likewise. I wondered whether anything was happening on that front.
Absolutely, Councillor Hutchison. That is something that our team manager, particularly in the mental capacity dolls team, is currently working on, so that we've got information that's kind of easily accessible, that can be translatable, so that we've got, when we've got any social workers who are talking about having to look at court of protection, then that information is accessible and available. And I think we've learned quite a lot from certainly kind of the challenges and the learning that we've had with the equal care, kind of report and the Buying Our Care report, so that we can improve our practice. So we've very much kind of taken that, and that is something that we're currently working on.
Okay, that'll be great to see. Thanks,
Yeah,
Lydia.
as soon as we've got anything in a draft form, we can share.
Yeah, please.
No problem.
Excellent. Thank you, Councillor Hutchinson. Thank you, Olivia, for the explanation. Nobody's indicating the moment, so if we can move on
to the Mental Health Act.
Yes, please.
Okay, no problem.
Oh, sorry, can we just bring Councillor Kingston's decided to put her hand up at the last minute?
No problem.
Thank you. I was waiting to see if Councillor Hutchinson might cover this. Myself and Councillor Hutchinson recently, about 3 months ago, I think, 2 or 3 months ago, attended a meeting with Nuri Sibyl, and they talked in that meeting about the issue with capacity assessments, which is part of this deprivation of liberties thing. And one of the things that they said in that meeting was that it's inconsistent that on the one hand, they're told that their relatives lack capacity, and therefore they've been moved into a situation where there's there's something that does a deprivation of liberty. I think it's this authorisation thing that's been authorised. So on the one hand, they're told that their family member lacks capacity, so decisions have been made on their behalf because of that lack of capacity. But on the other hand, in those care settings, relatives are being told that their relative has enough capacity to make decisions for themselves about what to drink, including for a Muslim person being offered and given alcoholic drinks. And it's that inconsistency of when somebody has capacity and when somebody doesn't have capacity, and the confusion of the relatives around that seems to be an issue. I just wanted to raise that question, that that relatives feel that there's inconsistency about whether or not their family member lacks capacity when they don't. Okay, about what to wear as well. You know, Muslim women in care settings placed there under orders, deemed to lack capacity, but deemed to be able to choose what to wear, and wearing what in Muslim culture is considered inappropriate clothing. That was clearly an issue.
I guess what I would be saying, Councillor Kingston, is that capacity is decision based. It's not an overarching, somebody doesn't have capacity, therefore they don't have capacity. Somebody may have capacity to decide what they want to wear, what they want to eat, but not have capacity to determine what their care and support needs are and how best those might be met. So I can understand that can be very confusing for families, because we can use that word capacity very loosely when actually it's a very, very decision focused. And I think that's something, again, that we can share with our providers and our practitioners in terms of when they're talking about capacity, to be clear about what decision that capacity has related to, rather than it being a global term of lacking capacity.
Thank you, Libby. Kath, do you want to come in on that as well, please?
Yes, well, Libby stole my thunder, actually. I was just going to say the same thing, that it can be very, very confusing. It's a very complex area of law, and the application of it has to be very sensitive, and it can be very confusing for people, but it is decision specific. So like Libby says, you know, you might have capacity, you know, particularly when people have got fluctuating capacity as well, that's even more tricky. You know, if they've got a level of delirium, for example, and that's a kind of a transient state, and you know, so they may still always retain capacity to make a decision about what they want to eat and drink, but not about, you know, where they want to live or their finances, etc. But I suppose the important bit is also overlaid around cultural competence, and so it's really important that when we're assessing people's capacity alongside people's family and involving and engaging people's family wherever possible, that we make sure that we're taking those wider issues into consideration around culture, ethnicity, religion, etc. So we're not making assumptions, but we do always have to assume that somebody has capacity as a starting point in terms of human rights, really. But yeah, so that's what I just wanted to add that. Thank you.
Thank you, Kath. Councillor Hutchinson.
Thank you. One of the key safeguards during the consideration of a standard authorisation that's described in the material that you linked us to is the appointment of a relevant person's representative. And it does say that the relevant person's representative will usually be a family member or a friend of the person who's being assessed. The number of people of Asian ethnicity subject to deprivation of liberty is small. You know, the last 2 years it's varied between 5 and 10. What are the reasons that a family member or friend might not be appointed as a relevant person's representative? And I wondered how many of the persons that are currently subject to DOLS have a family member or friend as their relevant person's representative.
Okay, I won't be able to, I can't answer the numbers, but I can see if we've got that information and come back to you. But the reasons might be very varied. So I think, as it says in the document, it could be a family member, a friend, or a commissioned advocate. So it does vary quite widely what those situations are. Sometimes it can be that a family member is not it has not acted in the best interest of that family member in the past, and there may have been some safeguarding issues. It's quite a complex area, so it's very varied, and when our colleagues are kind of looking at that, then there's a really detailed way that they kind of score and look at that in terms of in determining whether we would not use a family member or a friend as an RPR.
Because it does suggest that in general it would be a family member or friend, and it's only if there isn't a suitable person that a paid advocate would be appointed instead.
It's quite variable. I think there are families who choose to have a paid RPR rather than themselves being the represented person, and it's quite mixed. But what I can do is I can go back and see if we've got the figures in terms of the proportion of people who have a deprivation of liberty where we've got paid RPR versus family or friend.
Yeah, thanks. Particularly I'm thinking particularly of
in the South Asian community. Yeah, no problem.
Because although the person subject to deprivation of liberty safeguard authorization can apply to the Court of Protection to appeal against the best interest decisions that have been made and qualify for legal aid and official solicitor support to do that, this doesn't extend to family members who may wish to challenge those decisions unless they're the person's relevant person's representative. So it really takes it out of the practical realm for most families to engage their private legal counsel, I would suggest.
Yeah, we also have family members who kind of who have lasting power of attorney for either health and well-being or finance. So quite often that they would be acting on that person's they'd made an application through the court in order to get the order for that. So, but I will go and find out those figures for you, Councillor Hutchison, and come back.
Thanks a lot, because it does seem to be a fairly crucial decision that's taken on behalf of the person who's being subject to the authorization. Thank you.
Thank you, Councillor Barnes.
Thank you, Chair. I'm actually not sure where these fit, and I was going to hold my peace until the end, but I think we've moved a few questions on, and at this point, I think there's a few people in the room going to look at me with daggers. And I don't mean to be rude, but I was seriously underwhelmed by this report. It's very factual. I totally agree. It's very factual, but it doesn't actually say what it's like to be and what's happening to our residents and how it's impacting upon residents. So yeah, it's great that 3% or 4% or 8%, but it doesn't really get to what I think is what was aimed at within the Buy on Our Care report. I have got a couple of very specific questions. So I think, is it the Dales at Calderdale Royal?
We have the inpatient psychiatric unit at the Dales.
Yeah. So so if people are sectioned there, are people sectioned there?
They can be, yes.
Okay. Is there sufficient capacity? Are Calderdale people sectioned out at the Dales, or are they based out of authority?
When people are assessed under the Mental Health Act, then our local trust are the bed finders. So it depends on where there's a bed. So sometimes that can be in Calderdale, sometimes that could be across South West Yorkshire Partnership footprint, or it could be out of area.
So do we have those numbers?
I don't have those numbers, but I could contact our health colleagues to see if we can get those numbers. Our role in terms of Mental Health Act is purely an assessment role. and then once people are detained, then sadly it's where the bed is that people are placed.
Okay, so in a sense, therefore, do we have the same? Is it the delayed discharge discussion with the NHS that we have on acute physical health wards as well?
Yes, we have a weekly, what we call a MAID meeting, a multi-agency discharge event meeting on a weekly basis that looks at all Calderdale residents who are inpatient, regardless where they're inpatient, be that at the Dales or be that on another bed base within the trust or outside of the area, with the view of bringing that person back as quickly as possible to a local bed. So and then we also have a regular meeting around barriers to discharge, and then we've also got a regular meeting across the system where we are looking at crisis presentation within our emergency department.
Okay, I think I'll pause for now, Chair, and I might come back later if that's okay.
Okay, no worries then. Thank you, Councillor Barnes. Councillor Kingston.
Thank you very much. I just want to follow up on Councillor Hutchinson's questions about the relevant persons representative. You've offered us some data. I would like that to please be presented in a comparative manner so we can compare percentages of people from different ethnic communities. So how many people from white British families have got an RPR that's a family member versus a paid RPR compared to, basically what I'd like to see, is it more frequent that people from our South Asian community are given a paid RPR instead of having a member of the family appointed? I'd like to basically delve into that. So comparative data, please.
No problem. We can do that.
Super. Thank you, Councillor Kingston. Thank you, Libby. So if you want to now go on to the mental health.
Yeah.
Oh, yes, please.
Absolutely. So obviously it's the responsibility of the local authority to provide the approved mental health professionals. The approved mental health professional are autonomous professionals in their decision making, and that they act on behalf of the Secretary of State. So their role is one that I think they can be challenged on their processes and their thinking, but not actually on their decision making. We've given you kind of a range of different sections under the Mental Health Act, whether that's helpful or not. And we've given some kind of data around the kind of, that men are more likely to be detained than women. It's lower in people under 65. And in terms of the Black, Asian global majority, the detentions are 4 times higher than the white population. And again, the acronym of CTO is a care and treatment order, and again that is often used higher, and that care and treatment order is something that is applied to somebody in the community who has previously been detained under the Mental Health Act, and it will have some conditions attached to that, usually kind of things like medication compliance. And the data that colleagues have kind of given me here says that we've had an increase in detentions in kind of 5.7. In Calderdale, our level of detentions are the kind of the monthly sort of figures. So in September, we had 36 requests for a Mental Health Act assessment. Out of that request, 14 people were detained on Section 2, which is an assessment section that lasts for 28 days. 6 people were detained on a Section 3, and that could either have been somebody who has previously been on a Section 2 and after 28 days or up to 28 days the medic has recommended that they go to a Section 3, which is a section that means that somebody can be treated against their will. And then we had 1 person went in informally, and then we had 12 people that we assessed that were not detained, and there were 3 requests for a Mental Health Act assessment did not progress to a Mental Health Act assessment. Just for your information, anybody can request a Mental Health Act assessment, so that referral comes into us, and then the AMPs consider whether that will be kind of followed through in a formal assessment. And an assessment under the Act is by a social worker and 2 to independent doctors who are Section 12 approved doctors in order to detain anybody. In October, our figures, I think we had 8 people went into Section 2, 10 were Section 3, 6 people weren't detained at all, and 7 people weren't assessed at all. So not all Mental Health Act assessments lead to an assessment under the Act, and not all lead to a detention under the Act either.
Thank you, Libby. Councillor Barnes.
Chair, I haven't really got a question. I just want I want to say, so if people have questions, can I come back at the end? If no one's got any questions, I'll go now, but
just looking around, nobody seems to be putting their hand up. So go ahead, Councillor Barnes.
Okay. I think I'd like to go. I think this is the Scrutiny Committee rather than anything else. I think I'd like a further look at this, a more detailed look at this. I think we need to look at how, in relation, how it fits in with burnt bridges, our homeless people and people, how the flowchart's the wrong, how we present and that journey that goes through, and how people are affected, particularly those who are the most vulnerable in our society. And that was very evident within the burnt bridges review. And I just think we need a bit more work on this. Rather than just looking at the facts and figures, and I just think we need to do that, and I think that's going to cover both individuals here and also, from what we're saying, the hospital trust. Is that okay? And I've noticed Mike Lodge is panicking by his hand going on. Libby doesn't care, but Mike panicked.
I don't panic. You're fine, Councillor
Libby's too cool to panic.
Yeah. And Mike Lodge, please.
I wasn't panicking in the slightest, Chair. I just wondered whether this might be a topic for 2 or 3 members of the Scrutiny Board to look at a bit more, not as a detailed review, but to meet with Libby and 1 or 2 colleagues perhaps outside formal meetings, because one question leads to another, and I think sometimes the formal meetings isn't quite the right way of doing that. By all means, we can come back to a formal meeting, but actually Councillor Barnes has raised these issues, and Councillor Barnes and a couple of other people to just spend an hour and a half with whoever Kath decides, but Libby and colleagues, just to do us, okay, so what if that happens?
No, absolutely, Mike. I think that would be absolutely fine. I think it's I think it is an area that is really complex, and I know that I was speaking to colleagues the other day, particularly around a client who would kind of be part of that cohort that's at complex needs in terms of multiple kind of presentation, particularly around drugs and alcohol. And I know that dad would just love us to pick his daughter up and make her safe. But we do not kidnap people, so we have to kind of follow the Act, and we have assessed that young person under the Act several times, and they, sometimes that's resulted in detention, and sometimes it hasn't, and it's a difficult one. So more than happy to kind of sit in a room and have a really good chinwag about it, because there's a few of us around that know it very well.
Super, thank you. Thank you, Libby.
Chair, before Kath comes in, I must learn to shut up at these meetings, mustn't I?
Super. Thank you, Councillor Barnes. Kath, please.
Thanks, Councillor Bladbury. I think it's a really good idea, and I think to meet some working AMPs would be really helpful as well, and they can talk you through some live examples and some of the really, really difficult dilemmas and fine decision making that they have to do. I mean, I'm speaking as a former approved social worker, so it's a while back since I've practiced, but those decisions are the same, and the Act is mainly the same, and actually kind of appreciating that you are the person's advocate. You, as Libby said, AMPs are independent, they're acting independently and autonomously. And are accountable for those decisions, and the real crux of the role is to make sure that we apply the least restrictive alternative. So every AMP will be kind of horizon scanning for any kind of solution or alternative that would be suitable for that person. and these decisions are not taken lightly at all. And obviously there's a whole architecture of the law around your practice. And it's really tough sometimes when you've got two doctors saying this person should be in hospital, and I want this person detained under the Mental Health Act, to withstand that pressure and say, actually, I don't think that's the right thing for this person, given all the circumstances, all the social circumstances, the family, etc. I'm not going to make an application for this person's detention, and that's the role of the AMP really. So I think having some direct conversations with current kind of practice in AMPs would be really helpful.
Super. That sounds like a great plan to me. Okay, nobody else is indicating to speak. So thank you, Libby, for presenting and giving us the basics. I think it's been a useful discussion. I think it's equally going to be useful to have that individual, a few people meet with yourself or whoever that might be. So very much welcome the report. I think it's an issue moving forward. So thank you for your time. So that concludes item number 7. So you are free to go if you wish.
Thank you very much.
For the work
Nice
program.
to see you all again.
Thank you very much. Thank you.
Okay, bye-bye.
Thank you. So which leads on to the work program. So either Libby or Mike, between you.
I think, Libby, do you want to start?
Yeah, I'll start. That's absolutely fine. I think the main thing just to let members know is that since the papers went out, we've added an item for the meeting on the 7th of December. So we've got the annual report from Health Watch coming along next meeting. Mike, sorry, I'm sort of passing back to you straight away, but the next thing I've got written down is the volunteers for the Calderdale, Kirklees and Wakefield work, if you wanted to just pick up on that.
Yeah, okay, thanks, Libby. So you may remember that at the beginning June or July, we appointed to the Joint Scrutiny Committee to look at inpatient services in Swift for older people over 65. And we appointed, or you appointed, Councillor Blagborough, Councillor Ahmed, Councillor Carr and Councillor Durrance. The first meeting is in person in Wakefield on the 27th of November. And that presents difficulties for Councillor Carr and Councillor Durrance. So this is a bit of work that will probably stretch over 6 months, but will only be 3 meetings, touch wood, one in Wakefield in November and subsequent meetings in Huddersfield and in Halifax. So I suppose I'm putting 2 things to you, members. One is that we appoint a couple of subs for the November meeting, or alternatively, we replace Councillor Durrance and Councillor Carr in particular, who've got difficulties with the first meeting, and with 2 other members. So we have continuity over the piece of work. I can't imagine anyone's going to have their nose put out of joint through not having to go to a meeting in Wakefield. So
thank you. Councillor Bashad is going to volunteer, I think.
Yes, she is. Yeah, I'd be more than happy to take up the mantle on this one.
And super, thank you. And Councillor Kingston is going to be the second one that's going to be volunteering.
That's correct.
Super, brilliant. Let's appoint them as substitutes at the moment, and we'll see how that goes. Because if it's in person, it could well be that we need to continue those people and the continuity. So I think that covers that item. So thank you for that. So on to the next. Any other items, Mike?
Well, I think Libby's got one further thing to say, but just to say that Councillor Blagborough and Councillor Barnes and myself and Libby met with Kath and had a really productive meeting this lunchtime to look at the items that we're going to pull out from the Calderdale Cares Partnership Board Transformation Plan for discussion in the new year. And I think we came to the conclusion that it might be useful to actually have another offline discussion sometime in the new year with Kath about what is actually a fairly comprehensive and wide-reaching transformation plan. That doesn't mean it won't come back to the formal meeting in public, but I think Councillor Barnes was nodding there, and sort of there's a lot in it, and it probably is another one that needs a bit of unpicking in a sort of seminar mode rather than formal meeting mode. But then subsequently to bring some of those issues back into the formal meeting. The other thing just to say is that some of the aspects in that plan relate to the NHS much more exclusively, and I think probably Councillor Blackburn, Councillor Barnes may well need to meet with Neil Smurthwaite or Robin from the West Yorkshire ICB to see how we take those forward. And then they just if so, I'm going. I'll pause unless anybody if everyone's okay with that. We'll arrange that. And Libby was going to say something about the budget.
Yeah, I was also just going to briefly mention that, especially with having Jill and Councillor Pillai on the call, that the work on the care home market detail review is sort of picking up a little bit. We've amended the terms of reference based on comments from the last meeting and from comments sent over by Jill and Kath. So I'll share those with members if that's okay with you, Councillor Pillai as lead member, and then maybe start getting in touch with people about the next steps and any work that needs to be undertaken there. And then the final point, Mike's right, is about the budget seminar that we've got next month with all scrutiny councillors from all 4 boards. I mean, you'll all have had emails about this, but there's 2 sessions, one in December and one in January. The first that's taking place next month will just be an overview of how the budget setting works. Becky McIntyre, the new Director for Transformation Resources, will be in attendance, along with Councillor Dacre, I believe. Correct me if I'm wrong, Mike. So yeah, just a push there. If people can attend, I think it'd be really beneficial to get as many there as possible.
Super, thank you, Libby. And I just want to thank you for the work that you're doing in the background. You've really taken it on board, and you're doing a really good job. So yeah, well done. Keep going, because you're supporting us in an exceptional manner. So thank you for your support and encouragement on that. So I think that now concludes the items on the agenda. So I'd like to thank everyone for attending, for contributing, and I hope you all have a pleasant, warm and non-wet evening. So thank you very much indeed.
Thank you, Chair.
Yeah.
Everybody.
Thanks all.